I'm very, very happy to introduce our speakers for today. Dr. Russell Berg is a general internist who completed his training at the University of Washington School of Medicine and then his internal medicine residency, serving as Harborview Medical Center chief resident from 2019 to 20, following which he began work at the Red Lion Inn and Mary Pilgrim Inn hotel shelters. There he provides full spectrum medical care to 80 residents with chronic homelessness, high medical and behavioral health needs, including psychiatric, addiction, disability, and advanced age. He hosts approximately 20 learners in this space per month, from pre-medical students to fellows in addiction medicine. And he's involved in quality improvement work, implementing harm reduction and overdose response at the hotel shelter, and welcomes inquiries. Also, a speaker today is Dr. Clayton English, an assistant professor of pharmacy at UW School of Pharmacy. He practices in the ambulatory care setting as a psychiatric pharmacist at Harborview Mental Health and Addiction Services and supports UW Medicine's PGY2 psychiatry residency program. He earned his Bachelor of Science and Doctor of Pharmacy degrees from the University of Connecticut, followed by a special residency in psychiatric pharmacy and clinical psychopharmacology at Nova Southeastern University. He's board certified in psychiatric pharmacy and geriatric pharmacy. His clinical and research interests focus on psychiatric pharmacy, including mental health services provided by pharmacists, treatment of serious mental illness, and safety of medications for psychosis and mood disorders. Passionate about interprofessional education and student and resident well-being, he contributes to professional development through his work with the American Association of Psychiatric Pharmacists, including as a senior editor for their psychiatric pharmacotherapy review book and course. So I think you can see they have tremendous expertise to share with us today on aging with serious mental illness, and welcome to both of you.
Thank you so much, Barbara. I just want to check the audio is okay?
Yes, very good.
Oh, great, thank you. Thank you so much for this invitation. It's a privilege to be invited to speak to this audience. I'm very excited, especially to speak to such an interdisciplinary and broad audience, and also pleasure working with my co-presenter, Clayton English. Today, we're going to be talking about aging with serious mental illness. Barbara in the introduction already stated that I'm a general internist, so I just want to repeat that. And I am not a psychiatrist, but my work primarily focused on homeless health does it often involve treating patients with both advanced age and advanced mental illness. Both presenters today have no conflicts of interest to disclose. This is a outline of our talk today. I'll review serious mental illness and aging and touch upon the so-called silver tsunami of aging baby boomers that will be affecting all of us in the healthcare field. We'll touch on some challenges managing serious mental illness in aging patients, and then dive into some cases that will highlight some of the diagnoses contained within SMI. A first case of chronic schizophrenia with dementia. Then Dr. English will give an update on pharmacological treatment of schizophrenia in the aging population. Our second case will deal with a major depressive disorder with psychotic features, and then Clayton will provide an update on treatment for this condition in the aging population. And finally, I'll share a case of management of a patient with bipolar 1 disorder and who unfortunately suffers a lot of side effects from their treatment. And again, Clayton will update us on management of some of those side effects from antipsychotics. SMI in the aging population. SMI, or serious mental illness, is a pretty broad term, but I think most people agree that it includes the diagnoses of schizophrenia, major depressive disorder, especially with psychotic features, and bipolar 1 disorder. As many of us know, most schizophrenia is diagnosed in early adulthood, and overall, there's a lifetime prevalence amongst all populations studied of approximately 1%. In other words, approximately 1% of us will be diagnosed with schizophrenia by the end of our lives. About 25% of schizophrenia is diagnosed at age 40 or older, and this is called late onset schizophrenia. And so this is in the context of us understanding that most diagnoses of schizophrenia, about 75%, occur in early adulthood. People with schizophrenia tend to have approximately between a 10 and 15-year shorter life expectancy than individuals without a diagnosis of schizophrenia. And something that can complicate the diagnosis of late onset schizophrenia is that new onset psychotic symptoms may be a sign of neurodegenerative disorders that affect our aging patients. Depression with psychotic features, or psychotic depression, in contrast, has a mean onset later in age of approximately 51 years. Lifetime prevalence is about 0.35% of the population. But very importantly, especially for those of us and in the audience who work on the inpatient side of this situation, about 20 to 40% of patients who are hospitalized with depression present with psychotic symptoms during that admission. And so it's a very important thing for us to understand how to tackle and manage psychotic symptoms in individuals with depression, because so many of those individuals end up being hospitalized. And then finally, bipolar disorder 1 with psychotic features, or schizoaffective disorder, the different but related disorder. About 0.25% to 1% of elderly patients have bipolar disorder, and of those, almost half are diagnosed with mania late in life, so late onset mania. This is all in the context of a rapidly aging baby boomer population. So individuals born between 1946 and 1964, baby boomers. These individuals now are aging. And so you can see in this figure here shows the US population with of age 65 or greater in millions. And you can see this period, we're right in the middle of this, between 2010 and 2030. This is when baby boomers are now aging and aging 65 or greater. This has major implications for individuals in our field who are working with older people with serious mental illness. Because of that big population wave that's aging, we're going to be seeing more and more older people, more and more geriatric patients with serious mental illness, such as those 3 diagnoses that I've described. By 2030, those over 65 with a major psychiatric disorder will be roughly equal in number to those aged 30 to 44. And so we're just going to be encountering individuals with these conditions in advanced age more and more frequently over time. My clinical practice is actually focused specifically on individuals experiencing chronic homelessness. And I just bring this up because there's such high proportion of co-diagnosis of chronic homelessness and serious mental illness. There's both a cause and effect relationship between those two conditions. And interestingly, chronic homelessness disproportionately affects late baby boomers. I think that the reasons behind that are a little bit beyond the scope of this conversation, but these curves here show the age distribution of individuals, of single adult males experiencing chronic homelessness. And this data is from about 15 years ago already. So the peak of the curve back in 2010 was about age 50. Now that's 65, just again, reflecting those demographic changes that we're all working with. And also just to inform ourselves that we are going to be dealing with much higher levels of disability, profoundly disabling mental illness, and dementia in the chronic homeless population in our community and throughout the country. So I'll hand it over to Clayton.
Hello, everyone. Thank you, Russ, for that introduction to this topic on serious mental illness in the older adult population. So I want to introduce us into one of the cornerstone symptoms that we see across many of the diagnoses that fall under the umbrella of serious mental illness, and that's psychosis. And psychosis is characterized by significant impairment in several core areas. we oftentimes see difficulties with thought processes, so disorganized thinking, impaired reasoning, or difficulty following logical sequences and conversations. Psychosis can also affect affective responses, so inappropriate emotional reactions or lack of emotional reactions, which can cause a disconnection from certain situations. One of the big cornerstone symptoms and impairments within psychosis is this ability to recognize reality or loss of contact. This is oftentimes a hallmark feature of psychosis, and patients may not realize they are experiencing a distorted version of reality. And this leads to really a loss of touch with the real world. We can also see this ability of impairment with communicating and relating to others. So this may be in challenges, even just forming coherent sentences or struggling to engage socially in meaningful ways, which can have negative impacts on impairments. One of the challenges as well is the disorders that we see associated with psychosis and later in life. One is because some of the diagnoses that we can see are really more secondary to other causes. So actually, the majority of psychosis that we see in older adults is related to dementia causes, around 40%, whereas it's really only around 3% that are roughly related to schizophrenia spectrum disorders. We can also see drug-induced causes that can lead to psychosis, as well as delirium. And so oftentimes when we start seeing these things, the differential in ruling out various causes can be quite lengthy, and it oftentimes takes a bit of time. I think the big kind of takeaway on that, though, is that no matter what the condition, the psychosis in all of these conditions can oftentimes lead to deterioration of normal social functioning and lead to subsequent impairments. And so targeting it, understanding it, and recognizing it is really important for overall best management and care. Next slide.
I think it's back to me. We'll touch upon special challenges to treating schizophrenia in aging patients, and the cases that I'll present will highlight a number of these, but I kind of wanted to prime the audience a little bit. Older patients may have fewer and less severe positive symptoms of schizophrenia. So that means fewer hallucinations, fewer delusions, maybe less catatonia. However, the negative symptoms of schizophrenia tend to persist with age. And those are the symptoms that are associated with withdrawal, social withdrawal, isolation, self-neglect. I think I would put in this category as well. These are individuals that you may not see in your practice for months at a time because they're not presenting for medical care. Maybe you'll do a house call, or maybe you'll get a call from a concerned family member that their elderly parent just isn't doing well. And when someone checks on them, it just seems they are withdrawn, they are not caring for themselves, and they're no longer really engaging. Like Dr. English mentioned, there are often psychotic symptoms that present with neurodegenerative disorders that, of course, increase with prevalence as people age, including Alzheimer's dementia, Lewy body dementia, Parkinson's disease, amongst others. And then something that's very important, especially with individuals who are diagnosed with schizophrenia, for example, earlier in life and have been treated with antipsychotics for decades, rates of tardive dyskinesia, which is a movement disorder side effect that we'll touch upon in greater detail later, the rates of those side effects increase over time and are cumulative with treatment. So after 3 years of treatment with antipsychotics, up to over 50% of people have tardive dyskinesia or some type of movement disorder side effect. And unfortunately, in older individuals, and especially those with dementia, atypical antipsychotics have been associated with an elevated risk of mortality, a 1.6 times risk of mortality in those with dementia, as well as an increased risk of stroke.
Dr. Berg, I just wanted to mention that your volume has dropped a bit. If there's any way to increase your speaker or your microphone volume a bit.
Thank you. I'll try and do that. Yeah. Next slide is for Clayton. So I'll publish.
Great. So when we're thinking about treatment of psychosis and specifically thinking of psychosis associated with serious mental illness, so schizophrenia, depression with psychotic features, bipolar affective disorder, we're oftentimes faced with a balancing act with the pharmacotherapy management. It oftentimes requires some reconciliation of both benefits and risk. And there are several positives associated with our treatment. We know that psychosis is associated with poor outcomes, especially suicide being one of the most critical concerns with psychosis. Psychotic symptoms, things like severe delusions or hallucinations, can oftentimes lead to overwhelming distress, can lead to poor decision making, and that can potentially lead to things like self-harm as well as suicidal thoughts. And treatment can help mitigate this risk. We also know, especially when we focus on schizophrenia, treatment can make a difference, including improving quality of life, decreasing caregiver burden, as well as reducing the risk of losing housing, as well as enhancing functional outcomes. We also know that treatment likely prevents further progressive decline. The one challenge with this, though, is that this has largely been studied in younger populations relative to older populations. So that is somewhat of a limit with some of the literature. As we look at all of these positive effects that pharmacotherapy can potentially provide, we can't necessarily avoid some of the negatives associated with treatment. One point to make is that the antipsychotic drug class really actually lacks robust quality of studies performed in older populations. We predominantly see the robustness in younger individuals, those with early onset schizophrenia in their prime years, so 20 to 40 years of age. So we lack some of the evidence to guide us in those that may have late life schizophrenia or very late onset. And this often requires clinicians to use empirical evidence for treatment for many cases. We will go through some of the evidence and some of the clinical trials that have been performed, but unfortunately, the same amount of evidence or robustness that we have is not the same that we see in our younger cohorts. As Dr. Berg mentioned, there is the box warning of increased morbidity and mortality in patients with underlying dementia, which is something that we always have to think about in this patient population. And antipsychotics are listed on the Beers criteria list for inappropriate medications for older adults for select indications, so especially for use for agitation associated with behavioral and psychological disturbances associated with dementia. And so if we have concurrent dementia with serious mental illness, it can put providers a little bit in a tough call. And so it's oftentimes gaining informed consent, discussing both the positives of potential treatment, but also some of the risks that can be involved. And then adverse effects and drug-drug interactions, especially related to pharmacodynamic and pharmacokinetic changes, are oftentimes enhanced in older adults. Next slide. And that's a great segue into just a little bit of the reminder of some of the pharmacokinetic changes that we can see in older adults. I won't go through all of these elements, but I do want to point out some really important characteristics that may be very specific to antipsychotics, especially the hepatic system. Majority of our antipsychotics, both first and second generation drugs, are predominantly hepatically metabolized. They go through phase 1 oxidative metabolism, which is predominantly done through the cytochrome P450 isoenzyme system. We see reductions in oxidative metabolism as people age, thus the clearance of these medications is oftentimes going to decline as people get older. And so we oftentimes have to adjust that by using lower doses and being more mindful that the half-lives of these medications are going to be extended in older populations. I also want to bring up some of the central nervous system aspects. So one particular that we can sometimes forget about is the P glycoprotein transporters actually decreased in older adult patients. And this transporter really serves as a protective mechanism to get things out of the blood-brain barrier that shouldn't be there. And that's mostly medications and toxins. With that, we can potentially see medications not get cleared as quickly or more make it to the central nervous system. Additionally, one of the things that we can also see is the pharmacodynamic changes. So how receptor sensitivity changes, and there is change in receptor sensitivity and density in the central nervous system that can increase sensitivity to many central nervous system medications, including antipsychotic medications, which oftentimes have a multitude of actions, specifically many cholinergic receptors, alpha receptors, as well as histaminergic receptors. To give an example, many of our medications that we use are very highly lipid soluble because they need to make it to the central nervous system, and thus the activity is going to oftentimes be a bit more enhanced. Next slide. That said, too, we as clinicians and people who are taking care of the older adult population also have to keep in mind some of the burden and risks with polypharmacy. And this is also an area where we might have to reconcile some because our overall goal is to use the least amount of medications that we can, especially given the risk and the fact that some of these medications are going to be more sensitive in the older adult population. I do want to say there are some exceptions to keep in mind, especially when we're working with patients with serious mental illness, especially various different disorders, might require us to use polypharmacy on occasionally. And actually, for in some instances, polypharmacy is the recommended treatment of choice. A great example of this is depression with psychotic features, which is oftentimes going to require both the use of an antidepressant and an antipsychotic. We also have to keep in mind that adjuvant therapy is sometimes required given treatment emergent side effects. Dr. Berg is going to talk about a very difficult patient case later on today where our goal was to reduce polypharmacy, but the risk was too high, so we ended up having to use some additional medications to reduce the overall burden. And then we can't forget that augmentation, especially in cases of refractory illness, might be preferred both by the patient and the treating clinician. So our overall goal is, of course, if we can as much as possible to reduce the number of medications that we're using, but we might also have to give some give and take given the symptomatology of the patient population that we're working with. Next slide.
Okay, I think I'm back up. Barbara, is this volume any better?
A little bit.
Okay, I'll try and speak loudly. Our case one is dealing with a case of advanced aging, schizophrenia, and dementia. So this was a 78-year-old man that I met at the hotel homeless shelter who had a diagnosis of psychosis, a new diagnosis of psychosis, so late onset, and progressive dementia. He was released from a 30-year prison sentence in 2013 at age 71 and was unstably housed from 2013 to 2021. Couch surfing, he lived in his car for a while. In 2021, he came to medical attention basically for the first time, where he was admitted with urinary retention and a new diagnosis of psychosis, thought to be late onset schizophrenia. He was started on risperidone, and he was discharged from inpatient psychiatry to the hotel shelter in April of 2021. So this figure on the right here, I'll use a couple variations of this type of plot for this case. As part of my job, I think a lot about how to reduce unnecessary ER and hospital utilization. And one of the ways I can visualize that is to plot out cumulative hospital days over time. And so that's what this figure is. Every time this patient spent a night in the hospital, whether it was an ER visit or a night during a hospital admission, that cumulative number goes up by 1. And when they're out of the hospital for any period of time, that line continues horizontally. And so you can see he really had very little medical attention until his index admission in April of 2021, where he was admitted to psychiatry and diagnosed with late onset schizophrenia. After that psychiatry admission, he was discharged to the hotel shelter in April of 2021. And there we got to know him pretty well. We had medical appointments with him relatively frequently for common things in aging people like back pain. He had recurrent urinary retention. He had recurrent urinary tract infections, and then started to display progressive symptoms of confusion. Not remembering a conversation we had recently, and some starting to express some self-neglect. With risperidone, his positive symptoms of psychosis, such as hallucinations and delusions, were very well controlled, but some of the negative symptoms of schizophrenia persisted in him in the context of treatment, primarily social isolation. He really was in his hotel room all day, most days, and had very little contact with other individuals in the shelter and needed room visits, really, to progress his medical care. He was pretty withdrawn. He had not had contact with his family for many years, and it was thought that that wasn't likely to happen. Unfortunately, he had been in prison because of a sexual assault of a family member, and so really did not have any contact with his family, who did live nearby. In August of 2021, we sent him to the hospital after he had a number of falls at the hotel and increasing confusion. And there in the hospital, his medical workup was negative for other contributory causes for those conditions, for those symptoms. And there in the hospital, he was diagnosed with dementia, thought to be likely Alzheimer's dementia. He came back to the hotel shelter after that admission. And over the course of the early part of 2022, at the hotel, he had more frequent falls, more confusion, and was sent to the ER, often at night when he was falling in his room. He was sent to the hospital overnight by shelter staff. In July of 2022, we were able to start caregiver services for him at the hotel shelter, which was very helpful. But unfortunately, his symptoms of dementia became more progressive, and he started wandering off and getting lost in the community. One night, he was found at the bus stop in the rain in soaking wet clothing after being discharged from the ER after a workup for falls. He did agree to wear an Apple Tag necklace that we bought for him just so that we could find him in the community when he was lost. And that did help us locate him a number of times and bring him back to safety. However, in July of 2022, things just progressed further, and he was wandering into other residents' rooms, very disoriented, confused, and at risk of assault by other residents of the shelter, unfortunately. And also, he stopped eating. He stopped feeding himself. And so we sent him to the ER, where he was admitted for failure to thrive and grave disability. And then he was medically barred from returning to our hotel shelter because he was out of scope. Our residents have to be independent with their ADLs, and he clearly was not, unfortunately. And so this plot shows his admission in July of 2022, where he was admitted for failure to thrive. He ended up being admitted for over 6 months while guardianship was pursued by the inpatient social work team. A guardian was eventually appointed to him, and that allowed him to be discharged to a memory care adult family home. He then transitioned as his dementia progressed further. He was transitioned to hospice care and cared for by a geriatrician at the adult family home, and then passed at the adult family home in June of 2023. This case, I think an important thing to highlight too is how resource intensive these patients' care can be, especially nearing the end of their life. The last year of his life, he spent 208 days in the hospital. The vast majority, as you can see, was spent waiting for guardianship to be appointed. So I'll hand it back to Clayton.
So when we think about, the treatment and using risperidone from that example, the predominant pharmacotherapy management of late life schizophrenia remains the second generation or atypical antipsychotics. They've been proved the most effective, but I will give the caveat that most of these trials include patients who really actually developed early onset schizophrenia and then aged in place and lived longer with their symptoms relative to patients that developed new onset psychosis later in life. When we look and kind of dissect the evidence, most of the evidence supports the use of risperidone and olanzapine. There's been one of our largest randomized controlled trials was a comparator study. We'll take a little bit of a look at that in the next slide. But there have been some other randomized controlled studies that have looked at first generation antipsychotics and a few other second generation drugs. I will say, though, that most of our newer treatments that have been released really in about the last 10 years, we don't have much data, at least from a controlled trial setting, to know their effectiveness in the older adult population. But that said, since many patients who have late life schizophrenia actually develop earlier in the course of their life, we can use many treatments still. And again, it's still matching the best treatment for that patient that has worked oftentimes earlier in life too, to help manage their symptoms. The one thing that I will say, though, is that first generation antipsychotics, although they have shown efficacy, their use should be really limited in this population unless there is a really good history of response or someone has done well on the treatment, because these first generation drugs, especially our high potency D2 blockers like haloperidol and fluphenazine, they tend to have a much higher rates of developing tardive dyskinesia as in the older adult population. I also want to mention long-acting injectable antipsychotics. So long-acting injectable antipsychotics have classically not been used in the older adult population, or from some guidances were actually sometimes not recommended. This was due to the fact that there was concerns that the treatment had too long of a duration, and there was less that you could do to modify or change something, and many older adults have comorbidities that may influence that. And so if you need to make quick adjustments, you may not be able to. We are starting to see a little bit of a shift, though, in this. There have been some observational studies with long-acting injectable antipsychotics in older adult populations that have shown improved outcomes, such as reduced hospitalizations. Now, this hasn't been as confirmed in RCTs or in some larger studies, but there will be select patients that could benefit from a long-acting injectable medication, especially if adherence is a struggle. And talking, as Dr. Berg talked about, resource intensiveness and being able to locate and find patients, we do and are starting to use these therapies more for the benefit that it can prevent relapse and adherence. It's oftentimes just dose adjusting the medication appropriately for the older adult. Next slide. So this was the trial that I just mentioned. This is actually one of our larger randomized controlled trials. And this trial is actually fairly older now, I would say. It was published in 2003. And it was during kind of the heyday when many of the atypicals were relatively newer. This was a comparative trial of olanzapine and risperidone in adult patients older than the age of 60. It included patients with schizophrenia, schizoaffective disorder, including outpatients as well as nursing home residents. And the dosing for this was on what I would say the typical lower end that we see in younger populations. So that doses for risperidone were from 1 to 3 milligrams. So max that we generally use clinically 6 to 8, FDA max 16, which we never really go higher than 6 to 8, but 1 to 3 milligrams. And then olanzapine had a wider dosing range from 5 to 20. And about the average dose that patients received, it was close to 2 milligrams for risperidone patients and 11 for olanzapine. And the real big kind of takeaway, they use the positive and negative symptom scale as their main measure. What they found was that there was really no difference after 8 weeks of using either therapy. They found them both equivalent. And EPS-related adverse events were relatively low in both groups, although it did trend to be a little bit higher in olanzapine, and that likely was related to that the dosing range was a bit higher, where they didn't max. If I anticipated they had done the range from 1 to up to 6, then risperidone would have generated more extrapyramidal side effects. Clinically relevant weight gain was also noted in both groups, something that we expect with many of these patients. But overall symptomatic management, they were pretty much considered equivalent. And this is why oftentimes risperidone and olanzapine are still somewhat reached to for older adult patients based on some of this data. Next slide. There was also a meta-analysis that was conducted in late-life schizophrenia that was done in 2018. There were several studies that compared different antipsychotic treatments in older adults, and there were some mixed findings. One of the studies looked at paliperidone or Invega versus placebo. Unfortunately, they found no significant differences in efficacy. One study looked at olanzapine compared to haloperidol. Olanzapine was found to be much better and superior to haloperidol, looking at differences in response rates around 51% for olanzapine versus 29% for Haldol. So I think that's a big takeaway, is that still the second generation drugs are more preferred unless there is a previous history of response or good benefit noted with a first generation treatment. And then it also included some of the repeated trials with olanzapine and risperidone, one that we just talked about. But the overall findings for the meta-analysis is that there was really no major differences identified of the effects of these drugs in older adults. The main kind of takeaway that I pull from this is that the first generations generally are a little bit less preferred because of the extrapyramidal side effects. And then interesting enough, one of the placebo-controlled trials, paliperidone, didn't show any benefit. Next
Dr.
slide.
English, I don't know if you're going to get to this, but we did have a question about any experience with new antipsychotic Cobenfy, I'm going to mispronounce this, or previously Cartex.
So Cobenfy, I have not. Yeah, no, that's a great question. So I've had just a little bit of limited experience with Cobenfy, and then of course some colleagues that have used it. The biggest challenge that Cobenfy, for the audience, this is a new treatment for schizophrenia that works via the muscarinic system, so outside of the dopaminergic system. In reality, how the drug has its effects is potentially modulating downstream dopaminergic signaling. And this is done through some of its activity at the muscarinic 4 receptor and muscarinic 1 receptor. And the drug itself, it combines two products, xanomeline and trospium. And trospium is used to block some of the side effects that and I always butcher this, the xanomeline triggers. Because it has some cholinergic activity, so it can cause things like diarrhea, nausea, vomiting, and so the trospium helps block some of the peripheral side effects that can be generated. From what we've seen in practice, the biggest challenges is around the GI adverse effects. Nausea and emesis tend to be reported quite high with the treatment, but those that can tolerate it have generated some benefit. I think the hard thing right now is that we don't actually know exactly where it's going to fit as an augmenter, because most patients are already on a dopaminergic antagonist agent, and some of them which have anticholinergic activity, and whether that impacts the benefits of this treatment. So I think time will tell. For our older adult population with using Cobenfy, I think one of the biggest concerns is challenges is the trospium component, and that it can cause a lot of challenges with constipation, urinary retention, since you still are getting some of that peripheral anticholinergic effect. So hopefully that helps touch on that therapy a little bit. I think time will tell where we see it get incorporated. And I think we can go to the next slide. Yep. So antipsychotics in late life, this is, when we think about them, they do have side effects that we have to be conscientious about. This includes cardiovascular, sedation, anticholinergic, metabolic side effects, as well as extrapyramidal side effects. I won't go through all of these, but this is really meant to serve as just a reference for you, knowing that sometimes olanzapine, risperidone may not be the ideal agent based upon comorbidities. We might have to flex, especially if the patient has really uncontrolled diabetes. We may need to consider using things that are a bit more metabolically friendly, such as some of our D2 partial agonists like aripiprazole. So this kind of gives you an overview of some of the different side effect profile and balances. I would say, kind of a general rule that I follow when I'm teaching students, even though this is not all exclusive, there are exceptions to the rules. Many of our pine type drugs that end in PINE, clozapine, olanzapine, quetiapine, tend to be more metabolically problematic, but tend to be less problematic in regards to extrapyramidal side effects. Our dones, like paliperidone, risperidone, tend to be more problematic for EPS as well as hyperprolactinemia. And then our azole or dopamine 2 partial agonists tend to be very metabolically a bit more friendly, but can sometimes cause things like akathisia and restlessness. Next slide. And then just to be mindful that with our antipsychotics, we do need to be cautious of interpreting new disease states that can result from their use. So I know many people in the audience are aware of prescribing cascades where an adverse effect can become generated from a new treatment, and then it results in further treatment of the adverse effect. This is an example that I actually saw in practice with risperidone use for metabolic symptoms, where risperidone use for behavioral problems that generated some metabolic complications as well as some EPS, and then it was kind of a downstream management of the side effects. And so we really have to look at the risk versus benefit of each new treatment and evaluate for new side effects. It can be tough calls of whether to treat side effects versus switching and taking the patient's encounter and their voice involved. We have to keep that in mind as well. Next slide.
Okay, our next case is case 2, which is about a patient I helped care for with a major depressive disorder with psychotic features. This patient was a 75-year-old female. She had recently lost her spouse to long-term chronic illness, had no surviving children, and her nearest relatives were out of state. One of her concerned cousins, who's a patient of mine, flew to the East Coast to check on her and found her unkempt and hoarding, and possibly a bit malnourished as well. The patient, though, however, was able to fly back to Seattle to live with her relatives. Here in Seattle, she appeared confused. She was talking to herself. She had a vacant gaze and she had notable bradykinesia, or slow movements. She was taken to the ER by her family and was admitted to psychiatry. There, she was diagnosed with psychosis and also with catatonia and suspicion for cognitive impairment. While inpatient, she demonstrated some significant improvement with high-dose benzodiazepines, which are used to treat catatonia, as well as olanzapine. But she still had some persistent psychomotor slowing, and it wasn't clear whether she'd be able to live independently in her current state. While inpatient, she was trialed on electroconvulsive therapy and demonstrated a marked improvement with improvement in her psychomotor slowing and in catatonia symptoms. She was then discharged to an adult family home with ongoing maintenance ECT as an outpatient.
So as we're thinking about major depression with psychotic features, the major treatment of choice, as Dr. Berg was mentioning, is ECT. Also is generally our preferred treatment of choice if it's available. But for many, we're going to be using the combination of an antipsychotic, generally an atypical, plus an antidepressant. And to keep in mind, many of our antidepressants that we use, especially SSRIs, can have pharmacokinetic interactions where they can inhibit the metabolism of other medications. Good examples are fluoxetine, paroxetine, fluvoxamine. They can inhibit paroxetine and fluoxetine inhibit cytochrome P450 2D6. And many of our antipsychotics are metabolized through these. And so we're already going to see that decreased clearance in older adults. And then when we're adding drugs that potentially can interact, we may have to be more mindful of modifying the dose, especially of the antipsychotic, starting low and being conscientious that some antidepressants could increase the concentration of that. I'm not going to go through each metabolism pathway for the antipsychotics, but this is just kind of a nice reference for many of the treatments that we utilize, as well as some of the common drugs that come into play that can potentially increase the concentrations of these medications and put patients more at risk for adverse events. Next slide. So when we're thinking about evidence-based treatment options for MDD with psychosis, as I mentioned, ECT should be considered for severe presentations, especially if it's accessible or feasible. We'll talk a little bit about some of the challenges with that. But as far as medications go, we actually do not have any FDA-approved therapy outside of amoxapine, which was a tetracyclic medication that was predominantly used in the 80s. Has really kind of fallen out of favor. It tends to have a lot of TCA or tricyclic type qualities. It's the active metabolite of loxapine. And some of the studies that were done originally for it were not as rigorous as some of the newer combinations that have been studied. Most of our, not every combination of treatment has been studied in major depression with psychotic features, but there have been a few that have had some fairly large randomized controlled trials. Specifically, one of those is the combination of sertraline plus olanzapine. And comparisons are really kind of unavailable to the test relative safety and efficacy of individual antipsychotics and antidepressants. We would generally the guidance is we would start with one of our evidence-based regimens if a patient does not have a prior history or certain comorbidities that may guide our selection. probably the ones that we reach to in practice the most commonly are the olanzapine sertraline combination, as well as venlafaxine plus another atypical antipsychotic, so oftentimes quetiapine or olanzapine. We can consider other options, like I said, if the safety profile is not congruent. For refractory cases, there have been cases of using lithium as an augmenter that can pose some challenges for the older adult population. And this is oftentimes really after a person has failed to respond to the combination of an antipsychotic and antidepressant. And oftentimes before we engage really thinking about lithium augmentation, we try to get people into ECT if possible. There's also been some positive case reports for clozapine for more refractory cases, although clozapine poses a lot of logistical barriers and challenges, as you are probably aware about, especially in regards to the requirements for ANC monitoring and some of the especially orthostatic hypotensive sensitivity and sedation sensitivity that the older adult population can face with it. Next slide. I do want to mention, though, why there's generally a reach to if there's not compelling indications for the olanzapine sertraline combination. This is really our best studied combo in major depression with psychotic features. It was a study that was sponsored by the NIMH that looked at it acutely, as well as some maintenance, generated some maintenance data with it. And so our first study that was, published by Myers and colleagues was this 12-week double-blind randomized controlled trial utilizing the combo of olanzapine sertraline versus using olanzapine by itself. And the idea is that there was some thought that, well, if it's psychotic depression, you could just use an antipsychotic. If someone's presenting with psychosis, just use an antipsychotic because an antipsychotic will target that. And so they really wanted to study, well, does the antidepressant really make a difference? And it does. So the antidepressant is really an important part of the treatment approach. Rather than using the antipsychotic alone, you see higher remissions as well as higher response. And what was special about this trial was that a large portion of the patients, greater than actually 55%, were older than the age of 60. So it included older adults in it. This trial was continued for people who had a positive response. There was a 36-week randomized clinical trial that followed it to aim to assess the clinical effects of continuing the antipsychotic medication. So after you've had a good, robust response, do we need to continue the antipsychotic or can we let it go? And for so long, I was in the mindset that, the antidepressant was really the base that carried people through. The antipsychotic was only needed short term. And this continuation study really changed my line of thinking. What they found is that for the primary outcome, looking at relapse risk, it was much better to continue both of them. There were higher rates of relapse for those that discontinued the olanzapine component. So it was a 20.3%. Around 20% relapse in the olanzapine alone group versus 54% that were converted to placebo. So the antipsychotic really can be a maintenance treatment for patients with depression with psychotic features. It can oftentimes keep them well. So the study really concluded that continuing olanzapine along with sertraline helped prevent relapse. Next slide. But we do have to consider, of course, the adverse event profile of using an antipsychotic. And there were some notable differences between older adults exposed to the combination treatment versus younger. So I think one of the things that was noticed a little bit more is that weight gain tend to be more higher frequently seen in younger individuals compared to the older adult population. However, a big one that came out that people were more sensitive in the older adult population was extrapyramidal side effects. So specifically things like pseudoparkinsonism was higher in older adults. And we know olanzapine has kind of a built-in benztropine anticholinergic, so it tends to be a little bit lower risk for extrapyramidal side effects, but our older adults still are more sensitive to that. So that was a big takeaway when you compare the two age groups. The other one that was also a bigger takeaway, as you can see on the slide, is the pedal edema. So older adults are more sensitive to water weight retention and edema compared to younger people exposed to the combination. Next slide. And with that, it's a responsibility of us as providers and clinicians to monitor and manage these types of side effects, especially metabolic. The frequency of monitoring really doesn't change for older adults. We really need to assess weight, BMI, glucose status, either hemoglobin A1C or fasting blood glucose, and then manage treatment emergent side effects metabolically if needed. Of course, if people gain a lot of weight early on in treatment, we'll oftentimes switch first if we can, but if patients are doing very well on treatment, we may have to consider additional management. Next slide.
I'll chime in here. The patient case that I just presented demonstrated some of the tremendous efficacy that electroconvulsive therapy can have on individuals, especially when they are not able to achieve the level of functionality through medication treatment alone. I think this speaks to a question in the chat regarding how available ECT is, and is it available to patients as an outpatient? It is very logistically challenging, and I think the logistic challenges of ECT, as well as, of course, the memory effects, are the two biggest barriers to accessing this treatment. Initially, like during an inpatient stay, when ECT is often started, it needs to be done typically 3 times a week, and there really is limited availability in the community. That patient case that I presented was from a number of years ago, and that patient was able to access ECT through the VA system in Seattle. After the kind of acute treatment phase, like I said, which is 3 times a week, there's then continuation and maintenance ECT. And so individuals can be continued on ECT at a lower frequency for a long time, for months and years, to maintain remission of their symptoms. Individuals after electroconvulsive therapy are pretty dazed and confused, so to speak. They require an escort home. They're advised to avoid making important personal or work decisions while receiving treatment. And cognitive side effects are quite common, and that's typically described as some form of amnesia, either retrograde or inability to remember new events that they experience after ECT. Those side effects are common, but they tend to improve by about 2 weeks after treatment. If an individual is continuing maintenance therapy, and they experienced memory impairment or cognitive side effects from the treatment, they're likely to continue experiencing those as long as they continue ECT. And there are a number of important contraindications to ECT, including cardiovascular disease, pulmonary disease, and the presence of a pacemaker or an implantable defibrillator device for individuals. ECT functions by inducing a generalized seizure in an individual with electric current. As you can imagine, that person, if they have any type of electronic device in their body that's helping their heart function, that could really be damaged by that electrical current. So older individuals are expected to have higher prevalences of those contraindications. And so it can be challenging to safely start ECT in those individuals. That can be especially frustrating, especially given how efficacious this treatment often is for individuals. Now for our third case, which focuses and demonstrates some of the antipsychotic-induced movement disorders that Dr. English taught about just moments ago. This is a patient of mine in my primary care practice at Harborview. He was a 60-year-old man and an accomplished member of the criminal justice system in his home country. He and his family, however, received death threats related to his legal work, and he decided to move with his wife to live with his adult daughter in America, and that's when he joined my primary care panel. It turned out in his home country, he had had a prior diagnosis of depression, and many years before, he had attempted suicide at one time. When he moved to America, he was not on any pharmacotherapy of any kind, but was meeting with a psychotherapist in his home country. Unfortunately, shortly after moving to America, he was hospitalized, a psych admission, after he attempted to choke his daughter in a parking lot after an argument. And during that inpatient psych admission, he was diagnosed with bipolar 1. And it was thought that this act of violence against his daughter was a manifestation of a manic episode. Inpatient, he stabilized well on lithium. And then he established care with me. And when I got to know him, he had very well-controlled psychiatric symptoms. And he still felt like he had a lot of good years in him. He was in his early 60s at the time. He wanted to learn English. He wanted to get involved in his community, in his church. And he began volunteering to help people fill out residency applications, asylum paperwork, and citizenship paperwork. Unfortunately, about 10 years of lithium therapy led to a number of lithium-induced side effects, including hypothyroidism. He had a tremor, and then he developed nephrogenic diabetes insipidus, so polyuria. He was urinating frequently and large volumes, and this was associated with urinary incontinence, which was very embarrassing for him and really affected his ability to live the life he wanted to live. We made the decision in collaboration with his psychiatrist to cautiously titrate him off lithium to carbamazepine. But unfortunately, on carbamazepine, he had persistent hypomanic episodes and had to be admitted back to psychiatry a number of times to be stabilized. During one of those inpatient admissions, his therapy was changed to Depakote and olanzapine, which did control his hypomanic and manic symptoms quite well. But unfortunately, over time, he developed drug-induced Parkinsonism, as Clayton has mentioned, and this manifested in this patient with bradykinesia. He had difficulty initiating movements, he had rigidity, he had masked faces or kind of a lack of facial expression, and pramipexole was added to manage this side effect, but unfortunately with pretty limited benefit. He subsequently has had a number of admissions for falls, minor head trauma, and had to have a pretty prolonged rehab SNF admission, basically for balance training and to, for example, to help train him to get off and on of the on and off of the toilet safely and to be able to navigate his home environment with a walker. He is home now again, but continues to fall. And so both myself and his psychiatrist are kind of grappling with these treatment questions. Do we try to titrate or switch this individual to a different antipsychotic or mood stabilizer combination with fewer movement side effects, but risk a manic or hypomanic episode during that transition period? Should we add additional medications to manage these side effects? Maybe we should go back to lithium, considering how well controlled his symptoms were on that medication, and just accept the side effect profile that he was experiencing before. Or should we accept the movement side effects he's experiencing now as, I suppose, unavoidable, and the cost of having his psychiatric symptoms well controlled? We don't know the answers to these questions, and it's been an ongoing discussion with him and his family now for a number of years.
So as far as, thinking about treatment strategies for movement disorders, I think the first key thing is recognizing what movement disorder we're dealing with. Is it acute? Is it delayed? Is it hypokinetic? Is it hyperkinetic? Getting the formal kind of diagnosis will help best kind of guide some treatment strategies and approaches. When we're oftentimes thinking of some of our acute extrapyramidal side effects, we can break it down oftentimes into things like akathisia, dystonia, pseudoparkinsonism. Dystonia, the second one on the table, is generally less common in older adults. It tends to be a higher risk in younger individuals, especially younger males with high musculature build, and especially those that are using high potency first generation drugs. However, I will say that neurological comorbidities may increase the susceptibility. And so dystonia, when we see it often present, it's generally within the early use of the medication. So generally within the first few days after initiation of the medication or a dose increase. With dystonia, since it's a sustained, very painful muscle contraction, and depending on which muscles it affects, so if it can affect the laryngeal muscles, it could cause airway occlusion. We oftentimes consider it a medical emergency. Our strategy really is discontinuing it, immediately treating it with our antidotes. Oftentimes, this is a case where we would use an anticholinergic in an older adult or a benzodiazepine in an older adult to help provide acute relief, generally a parenteral product, and then, of course, switch to a different agent. Most of my encounters with patients, which has never been older adults with dystonia, but younger adults, it generally gives a very bad association with the medication. So although you can retrial it and using a prophylactic medication like an anticholinergic, it's oftentimes such a real bad distaste of using it that we oftentimes don't go down that pathway. What I do run into more problems, though, with older adults is akathisia and pseudoparkinsonism. So as Dr. Berg was mentioning, the patient that developed pseudoparkinsonism, patients that are older tend to be more susceptible to this, and especially if there is some comorbid neurological sequelae that can predispose them to the movement disorder. And then high potency agents, things like first generation high potency drugs like haloperidol, risperidone, paliperidone. But we even see this with our ones that tend to be more friendly, like Dr. Berg's example with olanzapine can cause this. I've seen this with one of the things that came out of one of the clinical trials that looked at aripiprazole as an adjunctive agent for depression in older adults was pseudoparkinsonism was actually, documented and was relatively higher compared to those that weren't exposed. So it does occur, even with our agents that we consider less than. In strategies, one of the strategies that we oftentimes utilize if people are doing well on the treatment, if we can reduce the dose, it oftentimes is dose related, so reducing can help in this situation. But if not, we may have to consider switching to other agents or consider cautious use of treatments to help alleviate the pseudoparkinsonism. Our treatment of choice is an anticholinergic like benztropine, but we know that poses a big risk cognitively for older adults. As Dr. Berg was mentioning, and their case example, using dopaminergic agents can sometimes be used as a sparing strategy, but the challenge there is that sometimes they can worsen the psychotic presentation. Akathisia, on the other hand, too, can be susceptible with older adults, reducing the dose if possible. And so just as a reminder, akathisia is that feeling of internal restlessness. It tends to be more precipitated by higher potency dopamine blocking drugs, as well as those that are using polypharmacy, especially SSRIs and SNRIs can increase the rates of akathisia. When we consider switching treatments for any of these, we are oftentimes trying to pick the ones that have the lowest risk, which are those pain type medications, especially quetiapine. In certain cases, we even go to clozapine for really severe cases. Medication-wise for akathisia, we can consider lipophilic beta blockers like propranolol. Benzodiazepines can also be used, but due to the risk of falls and liability with misuse, they tend to be a second preferred treatment strategy behind beta blockers. Next slide. And I think we're getting close to wrapping up. The last movement disorder that we want to talk about is tardive dyskinesia. This is not an acute form of EPS, but a delayed form, oftentimes after months to years of chronically using dopamine blocking treatments. Tardive dyskinesia tends to be a bit higher risk in women, those that have had a higher cumulative antipsychotic exposure over time, and then, of course, older age. We tend to see a real big risk with first-generation agents here. Kind of average, yearly risk of developing TD with a first-generation drug such as haloperidol can be as high as 5%, and that rate can double with each year of exposure, whereas with many of our atypical agents, it's generally much lower, generally in that 1 to 2% range, but there is still risk involved. With TD, the landscape has changed luckily over the last few years. Used to, we really would have to try to monitor, really heavily to prevent the development of this using the AIM scale every 6 months. And then if people started developing signs and symptoms, gradually switching them to a medication that may have a lower risk. And our drug of choice at that time was really clozapine. Luckily, we've had some newer therapies that have been more recently made available and easier to get our hands on. When these first came out, our VMAT2 inhibitors like valbenazine and 2-tetrabenazine, they were a bit challenging to get from a managed care standpoint, and now I'm finding them much more easier to use and seeing them used among more disciplines outside of neurology. So we're using them a lot more in psychiatry. I'm seeing medicine use them some. These are very effective treatments in treating tardive dyskinesia. The challenge with them is that they can reverse and cause the hyperkinetic movement that you see in tardive dyskinesia, like lip smacking, tongue protrusion, lip puckering. It can sometimes go the opposite way, where people end up developing more acute movement-like problems, like pseudoparkinsonism. And so that's one thing that we have to keep in mind with these treatments, is that the pendulum can sometimes swing the other way. We are using these in practice, seeing good treatment benefit where we can continue the antipsychotic. Valbenazine and 2-tetrabenazine tend to have similar outcomes. The one thing that I will say is that valbenazine sometimes, since it is dosed once daily, provides that advantage from an adherence standpoint compared to 2-tetrabenazine, which has to be dosed twice daily. And then a key other point I would say with tardive dyskinesia that is sometimes unfortunately done still in practice is that anticholinergics can actually worsen the symptoms, although they can be very helpful for treating the acute pseudoparkinsonian type symptoms. We do try to avoid them in TD, so that would be one of our first things that we really try to eliminate, and are really trying to eliminate them overall in older adults due to their Beers criteria status, as well as their impact on cognitive function. Next slide.
Great. And so we've reached the end. Just some key takeaways from a lot of this wonderful information that Dr. English has presented and some of the cases that I shared with you. That the older adult population presents unique challenges treating serious mental illness, especially with the increasing prevalence of co-occurring chronic conditions and polypharmacy. Pharmacologic treatment in aging patients requires careful consideration of efficacy versus side effects, particularly for serious mental illness conditions. Movement-related side effects from antipsychotics in particular are a very significant concern in older adults, especially how they impact an individual's ability to live independently and their quality of life. And a multidisciplinary approach and individualized care plans are essential for optimizing outcomes for our patients and addressing their complex needs. And so I just wanted to thank the audience so much. I wanted to thank Barbara for organizing, Dr. Clayton English for collaborating on this presentation together, and wanted to open up to questions.
Well, this was outstanding. I certainly learned a lot and really appreciated it. I already have a couple of questions. One was posed by Margaret in relation to the ECT. She's wondering, how would you describe the medical community's active support for perhaps increasing ECT facilities?
I know I can't speak to everyone, and I hate to speak to everyone by using, but my opinion is that I do wish that there was more, and I do wish there was more pressure or encouragement to build additional, facilities. But I will say some of the stigma that's associated with ECT, I think, still represents a big barrier for people to proceed with the treatment and to receive it appropriately. I know that the actual both infrastructure as well as workforce requirements can be a challenge due to the specialties that are oftentimes needed. I do feel that it is underutilized for many of our patients, especially those that have gone through several failures of treatment, as well as those with psychotic depression, given how effective it is, and oftentimes tends to be a bit more faster in onset relative to the drug therapy. So my hope is that there are people who are thinking about it and wanting to expand it. But I know in such a resource, stricken area, it's been harder to push, especially outside of some of the major metropolitan areas. I do see the link in regards to some of the expansion for the neuromodulation centers at UW, especially on the Northwest campus, which we're really excited about. And so there's, I think our system is really taking a good priority and making sure that those treatments are available, not only ECT, but some of the other neuromodulatory treatments that we didn't get a chance to talk about, like TMS. And even some of the more experimental ones where we're looking at more research into. Dr. Berg, did you have any comment?
I agree. I mean, it's just for those individuals who qualify and can access ECT and who need it, the effects can just be so dramatic and so positive. Yes, I hope the availability does increase, and it really does. The lack of broad availability does seem to be a major impediment to accessing that treatment. Maybe I'll address another question. I saw a question in the chat asking for recommendations. This person has a patient who scored low on a cognitive assessment and has symptoms of dementia and possibly major depressive disorder, but is adamantly against any sort of treatment and thinks providers are out to get her, thinks she's, quote, crazy, denies anything being wrong. I believe one behavioral health provider may have mentioned the word dementia, which the patient had a big problem with. How do you deal with it? A lack of insight into someone's own mental health issues unfortunately, is a common feature of a lot of these disorders. And it can be very challenging when that's coupled with cognitive impairment. That is a combination that I see very frequently in the hotel shelter setting where I practice. And it's really, really hard. Sometimes sometimes a fruitful approach can be to use motivational interviewing techniques and to elicit from the patient perhaps some symptoms of their mental illness that are bothersome to them, even if they don't wish to acknowledge that they have a mental illness. For example, a lot of people may experience anxiety associated with hallucinations. A lot of people may experience difficulty with sleep associated with symptoms of psychosis. And that can give you an opportunity to offer a therapeutic option to treat their underlying behavioral health disorder, but one that can specifically help with the symptom that bothers them. For example, quetiapine can be very effective to help people feel less agitated, less anxiety, and can help them sleep. And so, of course, if they ask me, is that an antipsychotic? I must agree that it's an antipsychotic, but I can say, I think in you, this may particularly give you some benefit to help with sleep. And it may just be an entree to help getting that individual started on treatment. Another strategy that we've used in the hotel shelter setting for individuals who are profoundly disabled is to offer antipsychotics by assent instead of consent. And what that means is someone, for example, who just isn't able to process a conversation, to participate productively in an appointment, I may say to them, I'm very concerned about your mental health. I'm worried you may be experiencing symptoms of psychosis. I'd like to prescribe a medication to you that can help you think more clearly. And I'll leave it at that. And if they don't say no, I'll prescribe that medication and have that available to them to try. And at least in one case, that's had profound positive effects on someone. Of course, they have the right to refuse. We're not compelling medication, but just trying to lower barriers to accessing that medication. That person may not feel able to say, yes, I want to begin treatment for schizophrenia, but rather just offer it to them, explain to them what it's for in very simple terms, and maybe they'll take it. And sometimes that can help.
That's helpful for you to raise that because I actually had a question. This is not really my area, but I understand that medication adherence in younger adults with serious mental illness is a challenge. And so I was just wondering, what are the similar challenges or lessons learned strategies for working with older adults in terms of ongoing medication adherence?
Yeah, it is a huge challenge. Long-acting injectable antipsychotics are wonderful. Dr. English described some of the cautions associated with their use in older people, but we do use them in the hotel shelter setting in older individuals and often to great benefit. And then something for individuals who are taking oral medications in our setting, we try and link medication adherence to other things, other perks. We call them carrots. When someone comes and takes their medication, we may offer them an Ensure. We may offer them something else that they like, a nutritional shake or something like that. And to just couple it with in a sense, a direct reward that can encourage them to take their medication more frequently. It does remain a challenge, especially with oral medications that require daily or multiple times daily dosing.
Yeah, thanks. That's helpful.
Yeah, and I echo Dr. Berg's comment regarding that. We're utilizing LAIs, long-acting injectable antipsychotics, more frequently. There's more flexibility with some of the newer products for dosing modifications and changing the time frame of administration, so the window. So sometimes it can be less frequent administration because of the clearance issues. So we're able to tailor some of the therapies accordingly. And then I would also echo some of the phrasing of how we discuss things. Again, focusing on what is of concern to the patient. Oftentimes, the vocabulary that the person uses will reflect something that the treatment will provide benefit to, and it's oftentimes a way that we can engage a discussion to make the treatment feel more palliative and beneficial for them.
That's perfect, because that plays into this focus on the 4Ms with what matters to them. We had one other question and just time for one other question. Ivan is wondering, how often have you seen hospital discharge delays due to lack of guardians?
Yeah, it's very challenging. I mean, chronic homelessness is kind of the ultimate failure mode for many problems, for severe mental illness, medical illness, lack of family, financial, social support. A lot of those individuals all just end up chronically homeless, and it's very challenging, especially when an individual isn't able to care for themselves. We pursue guardianship in the outpatient setting whenever possible. It is a long road. It takes many months, up to a year or more, to get a guardian appointed for these individuals. And we do it whenever possible in the outpatient setting to save inpatient hospital days and to save the system resources, as long as it's safe for that patient to remain in the outpatient setting. They need to, meeting their basic ADLs and be able to feed themselves, et cetera. It's a challenge, and we're not using guardianship to compel treatment or anything like that. That's a separate process. That would be a DCR or an ITA process here in Washington. Guardianship in those settings is primarily to get an individual placed in an appropriate setting, like an adult family home or a memory care unit, where they can be cared for safely. So very challenging, and unfortunately, there are just not any shortcuts, at least any that I've discovered so far, to speed that process up.
Well, and thank you both for the amazing work that you do. This was just outstanding, and I appreciate that there are professionals like you out there addressing these challenges. So thank you, everyone. Thanks for attending, and I will see you next week.
Thank you, Barbara. Thank you so much. Thanks for the invitation. Great working with you, Clayton. I hope we do it again.
Yes, thanks so much, Russell. It's good to work with you on this. Really appreciate it. Thank you again, Barbara, for the invitation to be here.
Well, of course, I think this is going to be a very popular YouTube video. So thanks much. All right,
Thanks again.
Good night.
Good night.